Assalamu alaikum. And let's move on to the third slide straight away, please. Can we go to the third slide, please? Yeah, the third one. So basically, a lot of this will be, the first few slides will just be a reiteration of what has already been said. I think I'm left with one main point to stress on. Convalescent plasma is obviously a blood derivative, very similar to the fresh frozen plasma, and a predecessor of the hyperimmune sera that we use for specific passive immunotherapy in so many viral infections, and it is obtained from recovered patients. A lot has already been said about the time when we can get the optimum concentration and the best titer, which determines the time of donation. As such, it is a form of passive immunity, and the higher the titer of the neutralizing antibodies, the better it is, as has already been said. The evidence in COVID-19 infection comes mainly from small numbers, from three main trials / studies in very sick patients and who were on other treatments. So actually evaluating the evidence is not great and is not very favorable and specific to COVID-19, but it has shown considerable success with some of the patients, and it is said to have reduced the viral load in many of them. The evidence has also been extrapolated from studies of using convalescent plasma and convalescent blood, whole blood in Ebola, for example, and in the previous SARS and MERS coronavirus diseases, and the influenza with very minimal benefit. And, it is quite variable from one disease to the other and from one virus to the other. Can I have the next slide, please? And basically, this is what we expect to get in terms of response or action. So the patient gets fresh frozen plasma, which contains clotting and anti-clotting factors, contains antibodies, albumin, other proteins. And what we really want to happen is this set of actions in panel B with antiviral effects, so neutralizing antibodies. And as Professor Jihad has mentioned and Amal has reiterated, we really need proper neutralizing antibodies, and I think this is the main problem at the moment. It can do other things like neutralizing complement factors and reducing the cytokines and doing other things that we know that immunoglobulin products can do, and this leads to immune modulatory effects of the immune system. So these are the presumed benefits of getting fresh frozen plasma. Can I get, or the convalescent plasma? Can I get the next slide, please? And the next one, please. Can we go to the one after it? So there are loads of difficulties and controversies related to this fresh frozen plasma product, or this plasma product, the convalescent plasma product, due to the fact that it's being used to neutralize a new virus and to treat a new disease. A disease that we don't know much about, and a new virus that is stunning us every day with new behavior and new activities. Loads of challenges ahead of us in terms of defining the neutralizing antibodies, although we have a good idea now that this might be the spike antibodies and other antibodies, and not the the anti-N antibodies. But then we are still faced by the methods of measurement and how to actually titer the antibody in the donated plasma and all that. The other difficulties would be the number of patients or the number of people who have recovered and who will be willing to donate. And recent evidence has shown that people with less severe disease, like what Shuaib has probably had, wouldn't get high titers of antibodies, while those with the severe disease get the higher titers. And this has got two things. So what kind of donors do we have? And how much antibodies are we going to harvest out of them? And when would be the optimum time of harvesting those antibodies? And when would be the optimum time of actually administering or giving the plasma to the patients to benefit from it? So, and is there any chance of using it as a prophylactic product? For example, to help our healthcare professionals not to self-isolate after exposure, or even when they are appointed as frontline. So all these are challenges, difficulties, and controversies, and I would like to move to the next slide, please. So there are also additional challenges which are directly related to the potential risks in using this as a therapeutic product. Being a blood product means that we have the potential of transmitting other infections, or the infection itself, the SARS-CoV-2 virus itself. And the other problem could be related to the non-transfusion reactions, major and minor, for example, the anaphylaxis and the Trali disease, the transfusion-related acute lung injury. The other main potential risk is actually related to the fact that it is an antibody-based therapy. And as Professor Jihad has mentioned, the main issue would be giving inadequate antibodies in your treatment, or the wrong type of antibodies, a lot more of the wrong antibodies, the non-neutralizing antibodies, and as a result of this, you may get what we call antibody-dependent enhancement of the infection. And this is a mechanism, an immunological mechanism, which has been noticed with viral infections, more so with the flaviviruses, such as the dengue fever and the yellow fever and all those. But also, it has also been seen in patients who were treated for HIV infection and for previous SARS infections. So the other side effect, I mean, putting all this aside and all these potential risks aside, the good news is that so far, on the few patients on which it has been tried, the only side effect that has been reported was actually a self-limiting facial erythema in 2 patients out of a total of about 20 patients in between 3 or 4 studies. And can I move to the next slide to show how this antibody-dependent enhancement may occur? So this is a picture just to demonstrate very simply how this paradoxical kind of mechanism works. So we are saying now that the presence or the transfusion of non-neutralizing antibodies, or even low-titer neutralizing antibodies, may provide an additional portal of entry for the virus to enter into cells like the phagocyte and the macrophages through their Fc gamma and Fc gamma 2 specifically receptors. And this would mean that the virus can evade our immune system by hiding in there and replicating as if nothing has happened. It surpasses so many other pathways. Had it come through, I mean, if it was a neutralizing antibody, it would have gone through the ACE2 receptor, and then it would have gone through the normal pathway downstream cytosolically, but because this is a different antibody, then it does not do that, and the immune system is evaded, and the virus gets the ability to multiply and infect our body even more. So this is a very interesting theory, and it's a very important theory that has been actually seen in previous infections, and has also been proposed as a method of severe disease in the patients who have got the severe disease and the very high antibodies. So basically, what they are trying to say is that perhaps these are not neutralizing antibodies. They are just high titer antibodies of other types, which are not specifically neutralizing to the virus. Can I move to the next slide, please? So how can we eliminate these sources of risk? The first one that I have mentioned, or the last one that I mentioned, was actually the antibody enhancement of the infection. And the only way I think that we can actually reduce or eliminate the potential risk from such a mechanism is better identification and titering of neutralizing antibody in the donated plasma. And also through the identification of the optimum time of administration of the therapy, because some people are saying that we don't really know whether this plasma that has been used in the so far mentioned trials has actually been useful to the patients or not, because it has been used with other treatments, and the patients were well ahead in the severity of their diseases. So we need better designed clinical trials, and which with better randomization, in order to understand this better and to be able to eliminate this kind of risk in a more scientific way. The other issue would be that of infection transmission, and I think we have gained a lot of experience with eliminating this kind of risk through proper donor selection and viral screening methods for other viruses. As for the SARS-CoV-2 virus, a lot has been said that whatever we are picking up on reverse transcriptase RNA after 2 weeks from recovery is probably just a false positive and not a true infection. So patients who are bled well after the second week would probably have good levels of antibodies and would have less chance of infecting their recipients. The transfusion reactions that we have mentioned can be dealt with by doing better patient and donor selection, and has already been mentioned by Dr. Jihad and by Dr. Harriet at the beginning, and also through perhaps the use of pre-medication, and more studies again and trials are needed to be able to optimize that. So can I move to the next slide? I think this is all I needed to say in terms of potential risks. There are loads of efforts happening at the moment all over the world. There is this COVID-19 Plasma Alliance that has been formed amongst all the major plasma fractionators and immunoglobulin producers, such as the big companies, and other firms are also contributing to this. Can I move to the next slide, please? And they have got a very nice website. They have got some basic information what is the plasma, convalescent plasma, and what is the difference between the convalescent plasma. And they are taking this further to the next step, which is the production of hyperimmune sera. But obviously this is going to take some time, and they need a lot of blood donations before they can actually reach a reasonable kind of product that they can put out in the market or for proper trials. And can I move to the next slide just to show you what has been done in Sudan? This is just a very simple method of proposing convalescent plasma as a treatment modality for coronavirus disease 2019 in Sudan. And can I move to the next slide? So basically, this group of researchers or this group of doctors have reviewed the literature, and they have elicited this proposal. And actually the design is very simple. It is mainly adapted to our very simple and basic kind of methods of extraction procedures and the capacity that we have in Sudan. So they conclude that this proposal has been prepared to the context of Sudan to be adopted by Sudan's health authorities as a treatment modality, and they are not actually saying that they are trialing this. So it is a very basic protocol, and we haven't, it is still being reviewed by the panels, the ethical panels and the research panels, and the other committees, and we're still waiting for the outcome. And I think that's all I wanted to say. Thank you very much, and apologies for all the initial kind of inconveniences.
Thank you ever so much, Nahla. You've done a great job from Sudan. I think